Hi, my name is Andy Lieberman, and today we're going to go over the pathology of degenerative disorders that affect the central nervous system, as well as several diseases that affect the spinal cord. So the goal for this lecture is for you to become familiar with the pathologic features of several dementing disorders that affect the brain, as well as the pathologic features of a number of movement disorders that also affect the brain. And then we're going to finish up by reviewing two disorders that affect the spinal cord. And there I'd like you to become familiar with the tracks that are involved by these diseases. So just to start with, it's important to note that for the degenerative disorders that affect the brain, these are not global pathologies, but rather affect selective populations of neurons. So the disorders are characterized by selective neuronal vulnerability. And in those areas that are selectively involved by these degenerative processes, one can see grossly atrophy in those areas. And that atrophy is a reflection of the fact that neurons have died in that particular area. So when we look under the microscope at the areas that are involved by these diseases, you'll see neuron loss as well as reaction by other cell types in the brain, including astrocytes and microglial cells. So there's neuron loss and gliosis. And then for many of these disorders, there are characteristic protein aggregates that we neuropathologists use to help categorize these diseases. So I'm going to start by reviewing the pathology of the most common dementing disorder, and that is Alzheimer's disease. So this is a disorder where the sites of selective neuronal vulnerability include the cerebral cortex, as well as deep structures within the brain, particularly within the limbic system. So this first slide here is from a subject at autopsy. Obviously the skull's been removed, the dura is reflected back, and you can see the normal convolutional pattern of the cerebral cortex. And I'm showing this so you can get a feel for the normal width of the gyri and the depth of the sulci. So in Alzheimer's disease, the cerebral cortex, as I mentioned, is a site of vulnerability. It isn't involving one particular lobe more than the others, but rather all the lobes can be similarly affected. And grossly one sees a narrowing of the gyri. Those hills are more narrow, and the sulci, the valleys between them, are widened. So you can see this in situ in the brain before it's been removed, and once it's been removed, it's really evident following fixation. So again, this is from a normal control. This is the frontal lobe, just to orient you, temporal, parietal, and occipital lobes. Down here, cerebellum and brainstem. And again, I'm just showing this so you can get a feel for the normal convolutional pattern of the brain, the normal width of the gyri, and depth of the sulci. So here's a similar view from a patient with Alzheimer's disease, and you can see that there's diffuse atrophy involving all of the cortical lobes. So we can see this on external examination, and you can also see evidence of this atrophy following cutting of the brain. So now we've sectioned, again, this is a normal brain, and we're looking at it at the level of the lateral geniculate nucleus. That's this triangular shaped nucleus down here. It's a relay in the visual system, and it's a convenient landmark that we often use to orient ourselves. And this is an important section because right below the lateral geniculate nucleus is the hippocampus, which is a limbic structure that's important for learning and memory. So what you can see here is the lateral and third ventricles. If you remember, the lateral ventricle is sort of a C-shaped structure. So on these cross sections, we catch the body of the lateral ventricle up top and the temporal horn down below. And the temporal horn is normally just a small slit. So looking at this same level in a patient with Alzheimer's disease, you can see the effects of the marked atrophy. So Those changes are evident on the cortical surface where the gyri are narrow and the sulci are wide. This is particularly evident in this case in the temporal lobe, where there's really severe atrophy. Again, this reflects the fact that neurons in the cortex are lost. So they're, under the microscope, you'd see neuron loss and gliosis. As those neurons die, their axonal extensions are lost and the white matter shrinks down. So all of this loss of brain substance leads to an expansion of the ventricles. So the lateral ventricle is widened, as is the temporal horn of the lateral ventricle, which, if you remember in the last slide, was just a slit-like structure, but now it's quite wide. And this also reflects that there is loss of neurons in the adjacent hippocampus, the other site of vulnerability in Alzheimer's disease. So now we're going to take a look at these changes microscopically. And this is a section that has been stained with a silver stain called a Bilshovsky stain. Down here is the surface of the brain, the peel surface. The gray matter goes from here all the way down to about here, and then underneath is the white matter. And the pathology that you see on silver stain are these dark brown stain structures that we're going to zoom in and take a look at higher magnification. So on the left-hand side is from a control subject, and on the right-hand side is from a patient with Alzheimer's disease. These big pyramidal cells are neurons, and you'll be able to recognize them as neurons because they have big nuclei, open chromatin, and prominent nucleoli. So all of these guys are neurons. So on the right-hand side of the panel is from a subject with Alzheimer's disease. There are fewer neurons, so there's neuron loss. If we had a special stain for activated astrocytes, you'd see the gliosis. In this case, we've used the silver stain that highlights the characteristic protein aggregates in Alzheimer's disease, which are neuritic senile plaques and neurofibrillary tangles. So plaques, if you recall, are these very large extracellular structures that are within the neuropil that are very complex and have at their center a deposition of A beta, and then surrounding them are dystrophic neurites, activated astrocytes, and microglia. So these are very complex and large structures. The other pathology that's highlighted on the silver stain are the neurofibrillary tangles. These are flame-shaped intraneuronal cytoplasmic inclusions of tau protein. So just show you a few more examples of plaques and tangles in the Alzheimer's disease brain. Again, these large sort of Brillo pad-like protein aggregates that occur within the neuropil are the senile plaques. You can see that they're much larger than the neuronal cell bodies that are adjacent to it. Again, these are very complex structures with an amyloid core and then a halo of dystrophic neurites, and it's the latter that's highlighted on the silver stain. And also here are numerous neurofibrillary tangles. This one is more C-shaped. Down here is one that's more flame-shaped. So those are the characteristic pathology features that one sees in Alzheimer's disease. The second most common cause of dementia in the population is Lewy body dementia. In these cases, the brain atrophy is typically not as severe as in cases of Alzheimer's disease, but there is usually modest atrophy, as you can see on this cross-section here, with dilatation of both the body and temporal horn of the lateral ventricle. The sites of selective vulnerability are slightly different, but extensively overlapping with Alzheimer's disease. In particular, we're going to look for involvement in the cerebral cortex, particularly in the cingulate gyrus, which is this gyrus which sits right above the corpus callosum. So this is a combination dye stain where the myelin, the white matter, is stained blue and the gray matter is counterstained pink. So this is the corpus callosum, and the gyrus sitting right above the corpus callosum is the cingulate gyrus, a site of vulnerability in dementia with Lewy bodies. So a very similar section from a patient with DLB. Here's the corpus callosum, and right above that is cingulate gyrus. You can see that there's a modest amount of atrophy here. It's smaller. The sulci are a bit more prominent. Also involved in dementia with Lewy bodies are limbic structures, the amygdala and hippocampus. So these are overlapping structures that are also involved in Alzheimer's disease. Here's a section of hippocampus from a normal subject, from a control subject. This is the lateral geniculate nucleus, that visual relay that I showed you in the Alzheimer's disease patient. Here's the temporal horn of the lateral ventricle. This is the hippocampus and the gyrus next to it, which we can refer to as the parahippocampal gyrus. This particular region in here is called the endorinal cortex, and that's where one sees pathology in patients with DLB. So this is a similar section from a patient with DLB. Here's the visual relay. You can see the enlarged temporal horn of the lateral ventricle. Here's the hippocampus, parahippocampal gyrus, and here's endorinal cortex, which will be abnormal in this disease. And finally, one sees brainstem pathology, most strikingly in the substantia nigra. So this is a section through the midbrain, red nucleus, cerebral peduncle, and right here is the nigra, where pigmented neurons hang out, and there'll be modest loss of those neurons and some pathology there. So the characteristic protein aggregate in this disorder is the Lewy body. This is a cytoplasmic protein aggregate that is an accumulation of the alpha-synuclein protein. And one can see Lewy bodies in all of the regions of selective vulnerability that I mentioned. And you can detect them on these dye stains as this sort of homogeneous pink aggregate that pushes the neuronal nucleus off to the side. So here's one and here's another one. They're somewhat subtle, but are brought out very nicely by an immunohistochemical stain against alpha-synuclein. So this dense protein aggregate in the cytoplasm of a neuron is a cortical Lewy body. One also sees this punctate staining in the neuropil. These are so-called Lewy neurites, like neuronal processes where there are accumulations of abnormal accumulations of alpha-synuclein. Okay, the third large group of dementias in the community population are the frontotemporal dementias. This is a more heterogeneous group, and I'm just going to show you one example of FTD, that being Pick's disease. So these cases have often very severe atrophy that's particularly involving the frontal and temporal lobes. In this case, you can see this very severe atrophy of the cortex bilaterally in the frontal lobes with very striking widening of the sulci. So that's the frontal lobe pathology. This is sort of at a bit of an angle. So frontal tips are here with severe atrophy, and there's also marked atrophy involving the temporal lobe, and in Pick's disease it often involves the anterior 2/3 of the superior temporal gyrus. On cut section you can see the extent of this atrophy is really quite severe, and it's really dramatic in terms of the dilatation of the lateral ventricle. So there's really striking hydrocephalus ex vacuo with marked enlargement of both the body and the temporal lobe, temporal horn of the lateral ventricle. And indeed, sometimes it's really hard to find the adjacent amygdala and hippocampus just because of the extensive neuron loss that's occurred in those regions. So the sites of selective vulnerability in Pick's disease are the frontal and temporal lobes, the amygdala, and the hippocampus. And this is a section of the dentate gyrus in the hippocampus from a control subject on the right and from a patient with Pick's disease on the left. So you can see that there's neuron loss. There would be gliosis in this region if we had a stain for it. And then what you can see even on this this dye stain is that the cytoplasm of these neurons seems to be abnormally distended in comparison to the control brain. And that's because there's a characteristic protein aggregate, which are Pick bodies. So Pick bodies are accumulations of tau protein It's actually the same protein that's aggregating in the neurofibrillary tangles of Alzheimer's disease. It just so happens that these are occurring in a different neuronal population. These are in the granule neurons of the dentate gyrus, and they often appear as these round cytoplasmic aggregates. So this is, you can see them on a silver stain. You can also see them really nicely on an immunohistochemical stain for tau. So all of these are PIC bodies. There are no there are no senile plaques in frontotemporal dementia, but there is tau pathology. The other change that you can see in many FTDs, including Pick's disease, are so-called balloon neurons or PIC cells. These can be present in the cortex or in the amygdala. They're neurons where the cytoplasm is markedly distended and filled with either tau protein or neurofilament protein. So those are the three dementing diseases I wanted to show you. We're going to switch now to a few movement disorders, the first being Huntington disease. So in this image, the top is a section from a subject with Huntington disease. The bottom is a control at the same level. You can see that the HD brain is smaller, so they're at end stage. There's diffuse neuron loss involving many structures, but the site of vulnerability that we typically think of in HD is the striatum. So that's in this region. You can see in the control subject, this is the caudate nucleus, the internal capsule, putamen and globus pallidus. So the head of the caudate typically bulges into the lateral ventricle. That's normal. In a patient who's died of Huntington disease, there's such severe neuron loss involving the head of the caudate that the caudate now becomes concave instead of convex. So what we're going to do is take a look at this region at higher power, looking at some of the microscopic changes that occur in Huntington's disease. So again, this is the combination dye stain where blue highlights the myelin and pink is the counter stain that we use to see gray matter. On the left-hand side is from a control subject. You can see the normal head of the caudate nucleus, internal capsule, and putamen. On the right, you can see the really severe atrophy that's occurred within the striatum in a patient at end stage with Huntington disease, with a very severe atrophy of these two nuclei. Okay, and this split screen image, that now sort of the order's been flipped. So the HD brain's on the left, the control is on the right. This is what the striatum looks like. There are these little stripes of white matter that are surrounded by islands of gray matter. So again, on the right-hand side is the normal appearance. On the left-hand side is from a patient with Huntington's disease. You can see that it's much more cellular. The cellularity is the gliosis, so lots of reactive astrocytes in there as a result of the extensive neuron loss that's occurred. And this can be brought out, this accumulation of reactive astrocytes can be brought out really nicely by a dye stain. This is called PTAH. It highlights reactive astrocytes with their spidery processes that are extending throughout. Similarly, if we used an immunohistochemical stain for GFAP, you could also see the abundant gliosis in the striatum from a patient with HD. Okay, the second movement disorder is Parkinson disease. This disorder affects the brainstem quite severely, and grossly you can see the changes very nicely in the midbrain. So on the right-hand side is the midbrain from a control subject. This is the substantia nigra, and these pigmented neurons give a very nice dark black appearance grossly. In patients with Parkinson disease, there has been sufficient loss of those pigmented neurons such that it's no longer black but appears brown grossly. So what we'll see when we look at the nigra or other pigmented neurons in the brainstem is neuron loss and gliosis in that region. So in this split screen image, on the right-hand side, you see the pigmented neurons in a normal subject. In the left is from a subject with Parkinson disease. There are fewer neurons. there's an accumulation of extra neuronal pigment, sort of tombstones of dead neurons. And then in some of the remaining neurons, one will find the characteristic protein aggregate, which is the Lewy body. So on this dye stain, this is a PTAH stain, you can see Lewy bodies really nicely. They appear as these round cytoplasmic targetoid protein aggregates. And this next slide shows a neuron with 3 Lewy bodies within the cytoplasm. So these Lewy bodies are biochemically exactly the same as those that occur in patients with dementia with Lewy body. So they'd be stained very nicely with an antibody against alpha-synuclein. The difference is the distribution. In a patient with Parkinson disease, they have brainstem predominant pathology, whereas a patient with DLB has also involvement of cortical regions. Okay, the next movement disorder I want to touch on is progressive supernuclear palsy. This is another tauopathy. So it's an accumulation of tau. Again, there are no senile plaques, and the distribution is very distinct from that involved in both Pick's disease and in Alzheimer's disease. So the sites of selective vulnerability in PSP are the globus pallidus. So just to orient you, here's the head of the caudate nucleus, terminal capsule, putamen and globus pallidus. So this is the region that would be atrophic, gliotic, and have occasional neurofibrillary tangles. So here's an abnormal neuron with a neurofibrillary tangle seen on silver stain. Also involved is the subthalamic nucleus. So again, just to orient you, here's third ventricle. These are the thalamic nuclei. And this almond-shaped nucleus below the thalamus is the subthalamic nucleus, the site of vulnerability in PSP. So there's neuron loss and gliosis in that region, and neurofibrillary tangles. And also involved by PSP is the substantia nigra. So these patients can have Parkinsonism. Again, the nigra sits between the red nucleus and the cerebral peduncle. There'll be neuron loss and gliosis in the nigra, but in a patient with PSP, they won't have Lewy bodies. Instead, they'll have neurofibrillary tangles, as shown right here. Okay, the final movement disorder is a disease called multiple system atrophy. We used to call it olivopontocerebellar degeneration, and although that old term is antiquated, it tells you very nicely the sites of selective vulnerability. So it involves the inferior olivary nucleus and the medulla, pontine nuclei, and the cerebellum. So again, here's the inferior olive, site of selective vulnerability in MSA. And then in this split screen image, you can see on the left the appearance of normal pons and cerebellum, and on the right-hand side, the pons from a patient with multiple system atrophy. The pons is atrophic, and what is lost are the neurons of the pons, the pontine neurons that are in these, just going to scorch over to the left-hand side, they're in these serpentine pink islands between the white matter tracts. So these neurons extend their axons to the contralateral cerebellar hemisphere. So what's lost in this disease are those neurons and their axonal projections. So one sees a loss of the white matter tracts, the crossing fibers, whereas the tracts that are going either up or down through the pons are retained. This is quite striking in the cerebellum, where the cerebellar white matter in control is very robust and large, whereas the cerebellar white matter in a patient with MSA is very atrophic. The incoming and outgoing fibers are lost, as are many of the Purkinje neurons. Okay, so we're going to finish up now with just 2 diseases of the spinal cord. And this is a normal cord, just to remind you that unlike in the brain, the spinal cord, the white matter tracts are on the outside and the gray matter is on the inside. So I just want to highlight first ALS. This is a disorder that affects both upper and lower motor neurons. And you can see the consequences of this degeneration really nicely on these myelin stains, or it's the combination stain that I've showed you a couple times now, where the myelin's blue and the gray matter's counterstained pink. So degeneration of the upper motor neurons in the cortex results in loss of their axons that extend down into the spinal cord. And those axons are bundled in the lateral columns. And so you can see where those axons are lost, there's now pallor in the lateral corticospinal tracts. See that really nicely as we zoom in a little bit. There's the lateral column with pallor. Here's the posterior column. These are the ascending tracts that carry sensory fibers, and that's got a normal staining intensity. Here's the central canal. This is the gray matter coming down like this. So this is the so-called anterior horn. This is where the lower motor neurons reside. It's another set of neurons that are affected in ALS. So there'll be neuron loss and gliosis involving the anterior horn. And when those neurons die, their axonal projections are lost. And of course, their axonal projections come out of the cord in the ventral roots. So what you see is very atrophic ventral roots, but a relative preservation, or a complete preservation actually, of the incoming dorsal sensory roots. Okay, the final disease process that we'll cover is a Psyringomyelia. This is a cavitary lesion in the cord that can occur secondary to a variety of insults, including congenital anomalies, trauma, or even a tumor. So these are cystic glial line cysts within the cord that are asymmetric and do not involve the central canal. So these are glial line cysts that that are asymmetrically placed and do not involve the central canal. And you can see on this combination dye stain, this pink region are the reactive astrocytes around the central cavity of the syrinx. And once again, the syrinx does not involve the central canal. These are the ependymal cells that line the central canal. These are normal in the adult. If the disease process didn't involve the central canal, it would be known as either a hydromyelia or a syringohydromyelia. So this is a nice diagram of a number of disease processes that affect the spinal cord. We've reviewed two of them. First, we did ALS. Remember, this is a degenerative disorder of both upper and lower motor neurons. Upper motor neuron degeneration results in degeneration of descending tracts that are bundled in the lateral corticospinal tracts. And then lower motor neuron degeneration affects the anterior horn, and the axons from those neurons leave the cord in the ventral roots. And we also touched on Psyringomyelia, which is an asymmetric cavitary lesion within the cord that's glial lined. Okay, thanks.